Good afternoon, doctors. On behalf of Hetero Healthcare, I, Dr. Prashant Kanteparkar, welcome you to this webinar on troubleshooting PCOS. Doctors, as you know, at Hetero, we market products in multiple therapy areas like in gynecology, dermatology, orthopedics, pulmonology, etc. With a very strong R&D support, we have developed many unique formulations, keeping patient benefit in mind. Our endeavor is to develop products, formulations or combinations which will finally improve patient compliance and ultimately clinical outcome. We have developed NSAID patches, rivastigmine patches to improve patient compliance. At Frenza, gynecology, obstetrics and IVF is an important therapy segment for us. We market products for vaginal health like Feminora, Pellitra, etc. We have formulated and introduced vaginal film containing lactic acid. In oral formulations, besides Dydropal and other products, we market Milotin, which, as you know, is a unique nutraceutical for PCOS management. Milotin contains myoinositol and dechiroinositol is a ratio of 40:1, chromium picolinate and melatonin along with folic acid and vitamin D. To speak more about PCOS and management with nutraceuticals, we have Dr. Shilpa Kotak today. Welcome, madam. Welcome, Dr. Shilpa.
Thank you.
Madam
Thank you.
has done her MBBS DGO from GMC Jamnagar. Dr. Kotak is working as an obstetrician and gynecologist in Akola since past 28 years, and Madam is running Kotak Hospital since 2000. Welcome to you once again, Dr. Shilpa.
Thank you.
Over to you for your insights. Thank you.
Today I am going to talk about the troubleshooting PCOS. Second slide, please. Next slide. PCOS, it is a complex disease. It affects 50 to 70% women having hirsutism, 50% of women facing menstrual problems, 5 to 10% of the patient developing obesity, 30 to 35% overweighted, and 50 to 70% of patients having insulin resistance. Next slide, please. Every 1 in 5 women in India suffers from the polycystic ovarian syndrome. Next slide. What is polycystic ovarian syndrome? It is a hormonal disorder causing enlarged ovaries with a small cyst on outer edge of the ovaries. Generally, it should be more than 10 to 12 in numbers and size between the 2 to 9 millimeter. It usually only diagnosed when complication develop that significantly reduce the patient's quality of the life. That's patients having hair loss, alopecia, acne, and infertility-related problems. Causes, next slide, please. Causes of the PCOS. PCOS isn't well understood, but may involve a combination of genetic and environmental factors. Environmental factors like sedimentary lifestyle, stressful life, and eating bad habit like fast food. Next slide. Symptoms of the PCOS. Symptoms appears in a different way. There may be a menstrual problems, acne problems, obesity problem. There might be a melasmic problem and infertility problem. And some may have come to us with the psychological problems like anxiety, depression, mood swing, reduced quality of life, and poor self-esteem. Metabolic features in the form of the insulin resistance, diabetes mellitus, and CVS complications. Reproductive in a form of the irregular cycles, absence of cycles, heavy menstruation following a long amenorrhea, short and scanty cycles, according we can find a patient due to high level of the androgens. There is a excessive hair growth on the face and body. Male pattern baldness also I have found in some patients. Abnormal hair growth generally found in the 70% of the PCOS. And also there is, due to the excessive androgens, there might be some thinning of the hair also. Acne. PCOS can cause acne, especially it found start from the teenage and difficult to treat by simple acne vulgaris treatment. Obesity. Obesity, between 40 to 80% of women with PCOS have obesity. There is typically increase in the abdominal and waist circumference, and difficult to reduce the obesity is the most commonly found in PCOS patients. Darkening of the skin or melasma. We found patches of dark skins, especially in the front of neck, armpits, inner side of the thighs, and under the breast. Reproductive problems in the form of infertility. Next slide. Diagnosis of the PCOS. PCOS generally can be diagnosed by sonography or by a laboratory test. Diagnosis of PCOS in USG, more than 10 cc of ovaries with a peripherally arranged small follicles, which should be more than 10 to 12 on the baseline sonography, that is first 5 days of the cycles, and each follicles is around 2 to 9 millimeter in the size. Lab investigations. Lab investigation in the form of hormonal assay. There is excuse me, there is increase in luteinizing hormones. There is increase in luteinizing hormones and FSH ratio, and decrease in the follicle stimulating hormones. Hyperandrogenemia in a form of increased free testosterone level. There is increase in the insulin level and decrease in the glucose tolerance. Next slide. Pathophysiology of the PCOS. High consumption of carbohydrates, hyperinsulinemia, hyperandrogenemia, persistent low-grade inflammations are the major cause of the PCOS. Complications, next slide. Acne. The prevalence of acne is 12 to 14% among a white woman with PCOS, higher in Asian Indians women of the Mediterranean descent, approximately 25%. Next slide. Next slide. Alopecia. Androgenic alopecia, disturbing scalp hair loss in women, also can result from the hypoandrogenism and is recognized but uncommon feature of the PCOS. Less than 5% of women with PCOS complain of hair loss. Typically, the hair loss is limited to the crown and does not involve the frontal hairline. Next slide. Next slide, please. Ovulatory and menstrual dysfunction. The normal intermenstrual interval range between 21 and 35 days, and menses that occur less or more often are indicated of ovulatory dysfunction. Less than 21 days and more than the 35 days are pathological. Normal range is between 21 to 35 days is considered. The major women of PCOS, approximately 60 to 85, exhibit gross menstrual dysfunction in a form of heavy menstrual cycles, scanty menstrual cycle, irregular menstrual cycle, no menstruations, or late menarche. All this can be found in the PCOS patients. The most common abnormality are oligomenorrhea and amenorrhea. Next slide. Next slide, please. Polycystic ovaries take its names from the enlarged polycystic ovaries so commonly observed in women with the hypoandrogenic chronic and ovulations. Polycystic ovaries typically exhibit increased size and stromal volume and an increased number of the small follicles. The Rotterdam criteria consider only the total number of follicles required 12 or more, measuring 2 to 9 millimeter in diameter, in both ovaries or in minimum one ovaries. Next slide. Polycystic ovaries. The prevalence of polycystic ovaries is quite high among the women with androgen excessives, that is more than 80%. However, from 8% to 25% of a normal woman and even 40% of women using oral contraceptives also meet the ultrasonographic criteria for polycystic ovaries. Moreover, polycystic ovaries are commonly observed during normal pubertal development and even in the woman with hypothalamic amenorrhea and hyperprolactinemia. In the 2003 Rotterdam diagnostic criteria expanded the populations of women that might be assigned a diagnosis of PCOS by approximately 50% compared to the criteria earlier recommended by the NICD-HD due to entirely to the inclusion of the polycystic ovary. Next slide, please. Abnormal gonadotrophin secretion. Increased serum LH concentrations, low normal FSH level, and increased LH-FSH ratio are typical, but more so in lean than in obese women with the PCOS. Lean women have this type of the LH-FSH ratio disturbed. Generally, we can found in this lean patients. In the past, an increased LH-FSH ratio, that is 2:1, more than 2:1, has been regarded as the marker of the PCOS. But the ratio varies with the assay used to measure gonadotrophin concentrations. Consequently, gonadotrophin level or a ratios are not a reliable diagnostic criteria. They neither make nor exclude the diagnosis. Next slide, please. Insulin resistance. The overall prevalence of insulin resistance among women with PCOS is between 15 and 75% and greater in obese than in a thin and lean woman with a PCOS. Most women with PCOS and insulin resistance are young and have an ample pancreatic B cell reserve. Consequently, they are able to generate a compensatory hyperinsulinemia, allowing them to maintain normal glucose homeostatic at least in the fasting state. Next slide, please. Dyslipidemia. Dyslipidemia is most common metabolic abnormality observed in women with a PCOS. Nearly 70% have at least one borderline or elevated lipid level. Insulin resistance and hyperinsulinemia are associated with decreased high-density lipoprotein, cholesterol, and elevated triglyceride levels. Some also have observed elevated low-density lipoprotein LDL concentrations. Next slide. Infertility. Infertility affects 40% of women with the PCOS. PCOS is most common cause of the anovulatory infertility. Approximately 90 to 95% of anovulatory women presenting to infertility clinic have a PCOS. In addition, spontaneous abortions occur more frequently in PCOS with incidence ranging from 42 to 73%. Inherent ovarian disorder studies show reduced rate of the conception despite therapy with the clomiphene citrate. Next slide. Investigation. Serum testosterone level, dehydroepiandrosterone level, 17-OH progesterone level, serum TSH level, serum prolactin levels, serum FSH and LH level, total estrogen level, SHBG levels, lipid profile, AMH level, TVS necklace pattern of the follicle arrangement is characteristic. 2 hours oral glucose tolerance test. Next slide. Next slide, please. Goal of treatment. Regularization of the cycle, improving insulin sensitivity, reduction of the weight, improve fertility, and decrease the androgens. Next slide. Next slide, please. Management of the PCOS. PCOS is condition that span the life of woman. Fetal programming may represent the beginning of syndrome characterized by HA and IR, which can have a series of medical consequences in adolescent, adulthood, and old age. Menstrual and fertility problems evolve into metabolic complications as age advances, with early diagnosis being crucial if the aforementioned sometimes fetal complications are to be avoided. A precise diagnosis is important, especially at the extreme end of the reproductive lifespan. Lifestyle therapy tends to be the first step in PCOS management, especially when excessive body weight is associated with the PCOS. Pharmacotherapy is frequently used to manage the most problematic manifestation in age group, such as irregular menses, hirsutism in adolescent, fertility problem in adulthood, and metabolic problems and risk of the cancer in old age. Next slide. Lifestyle improving outcome. Healthy lifestyle improves the outcome of the PCOS. Healthy lifestyle in a form of a regular exercise, low intake of the carbohydrate and fat, dairy and bakery products should be avoided. Exercise in the form of the brisk walking for 30 minutes, fast cycling for 45 minutes, swimming, skipping, jogging, all type of the exercise for minimum 30 to 45 minutes. Next slide. Pharmacotherapy of the PCOS. Low androgen oral contraceptives that contain drospirenone or progestin only pills known as a mini pills, and ionocetal supplement, myoinositol and D-chiroinositol, or a combination of two, which can help to manage PCOS symptoms such as hirsutism, acne, and infertility. Metformin, lipid lowering and with lipid abnormalities. Next slide. Next slide. Current gap in the treatment. There are different problems and different type of the patients are there to manage. Lean PCOS only for the correction of PCOS, infertility and lean patients, and correction of PCOS with ovulations. Obese PCOS, correction of PCOS and weight reduction. Insulin PCOS, correction of PCOS and insulin sensitivity. Hormonal imbalance PCOS, they need correction of PCOS and hormonal cycles. Next slide. Next slide, please. Addressing the gap. Active ingredient myoinositol and D-chiroinositol 40:1 ratio regularize the menses, improves egg quality, and restore the ovulations. Chromium picolinate improves the insulin sensitivity. Melatonin improves the oocyte quality. Vitamin D3 improves the ovulation And folic acid improves the oocyte quality. Next slide, please. Next slide. Myoinositol and D-kyoinositol. In PCOS studies saw a 500-fold decrease in the myoinositol level of the ovaries. Follicular development is impaired owing to the reduced myoinositol level in the ovaries. Combined dose of myoinositol and D-kyoinositol is administered with the found to be extremely beneficial in the treatment of PCOS. Myoinositol has a substantial role in the ovulation, while D-kyoinositol has a role in insulin resistance that improves the insulin sensitivity. So there is a medical rationale to administer them together. Thereby, the combined administration of myoinositol and D-kyoinositol in a physiological plasma ratio that is 40:1 is considered as a first-line approach in the PCOS patient. Next slide, please. Next slide. Next slide. Next slide. Benefit of myoinositol and D-kyoinositol in a ratio of 40:1. Myoinositol and D-kyoinositol are two stereoisomers of inositol and insulin sensitizer. In a human ovary, myoinositol is the second messenger of the FSH, and myoinositol mediates FSH signaling. D-kyoinositol is the aromatase inhibitor. Thus, myoinositol and D-kyoinositol in a ratio of 40:1 allow a treatment of polycystic ovarian syndrome. Myoinositol and D-kyoinositol ratio were able to improve the regularity of the menstrual cycle, acne score, the endocrine and metabolic parameters, and insulin resistance in the PCOS patient. Next slide. Chromium picolinate. Chromium picolinate is combined with a picolinate in order to increase the gut absorption. When given in PCOS, it reduces the hyperinsulinemia and hyperandrogenism. It acts by enhancing insulin signaling. It improves insulin sensitivity and helps to reduce the fat. It is better tolerated than the metformin. The combined action of both inositol and chromium picolinate on insulin regulation will help to treat the underlying cause of the PCOS. Next slide. Next slide. Next slide. Next slide, please. Melatonin. Concentration of melatonin in pre-ovulatory follicle fluid is lower in women with the PCOS. Melatonin supports nuclear maturation of oocyte in vitro. Melatonin administration may be useful in vitro fertilization strategy and improves clinical outcome of PCOS. Therefore, melatonin may provide improvement of oocyte quality and increased pregnancy rate. Melatonin is a sleep-inducing hormone, and melatonin also reduces the stress level in a patient. Next slide, please. Next slide. The role of melatonin in polycystic ovary syndromes is found in so many of the cases. Next slide, please. There are 3 to 4 trials. They improve the use of the melatonin will improve the fertility in patients with a PCOS. Next slide. Next slide, please. Folic acid and vitamin D3. Folic acid helps to manage infertility rooted in ovulation problem for both women with or without PCOS. Vitamin D3 may play a key role in helping some women seeking treatment for polycystic ovarian syndrome and related infertility get pregnant. Next slide. There are a lot of case studies. I had used these products for a different cases. I had used it for infertility without melatonin, without mylotin. I had used ovulation inducing tablets and plain minoxidil DCI combinations, but not able to fertilize the woman. Along with ovulation inducing agent, I had used mylotin in this 5 to 7 patients, and I got a good result. They had a good ovum, they had a good endometrial lining. There is also better outside quality, and patients become pregnant also, and now they are having 4 to 5 months of the pregnancy. For the management of the cycle regulation, I simply used mylotin tablet, these combinations in girls, adolescent girls with a lifestyle modification, regular exercise, diet, and only non-hormonal tablets that contain D-chironocetal and this mylotin tablet. They got a regular cycle with a regular flow, and there is no problem after stopping of the combinations, lifestyle modifications, and regular checkup they needed for a lifelong, because the PCOS is a condition that cannot be treated by a simple one-step medications. They PCOS patients required lifestyle modifications, and in between they also required some medications. D-chironocetal, myochironocetal in a combinations with this melatonin, so chromium piconate, all these combination will help in fertility. It also regulate the cycle, and it also help to reduces the acne in some patients, because hormonal treatment cannot be given for long period of the time. Along with the hormonal therapy, if we use these combinations, then there is a good treatment for the acne also. I had used this combination for fertility and for a treatment of the menstrual irregularity. And in both the cases, I used with metformin also and plain also. Metformin, sometimes it cannot be tolerated by all the patients, but mylotin tablet is well tolerated by the patients, and I am using in BID doses. For a long time, if patients are adolescent having only obesity with hirsutism and all those problems, then I am using it with 2 to 3 cycles of the hormones along with these combinations for a 6 to 9 months, and they got a good result. Okay, thank you.
Thank you very much, doctor.
Thank you.
Thank you for sharing your insights. There are a few questions, if with your permission, I will hear.
I can answer it. No problem.
Some of the questions were in which type of PCS would actually prefer this type of combination? By that I mean, is it a reproductive PCOS or metabolic PCOS?
I am using for both the purpose, for metabolic purpose and infertility. For infertility, I should to use with the ovulation inducing agent also. If we are using only clomiphene citrate, then there is anti-estrogenic problems also. But I am using letrozole, though there is a not an endometrial thickness, we can't found, and sometimes good oxide also we can't get by simple. In these cases, if I am using with a ovulative stimulating agent and mylutein, then and folic acid also, plain folic acid also I'm using, patients are getting good ovulations, and they conceive also. In metabolic problems, we advise a lifestyle modification along with these combinations. These combinations can be used for a 6 to 9 months. I am using for minimum 3 months. And if they are reducing their weight, so they can have a improvement on acne. Their abdominal circumference are also getting reduced, and with whatever effort they are taking, they can reduce their weight also. Lifestyle modification must be there for a metabolic disorders, and for the infertility, I am using these ovulation inducing medicines also. And for supporting luteal phase support also, we need medicines. But due to mylutein, we are getting a good oxide, and fertility rate is increased as compared to plain metformin and other medicines, because it is a combination of all the ingredients that will improve the fertility rate also.
This would work well both in the lean as well as obese PCOS.
Yeah. It will work on.
Is type of PCOS weight related, madam?
What? I can't understand.
I mean, whether the PCOS is reproductive or metabolic, is it weight related? Like something is common in lean patients, something is common.
Lean and lean patients can be managed by only these combinations. But for the obese PCOS with infertility, it is necessary to weight reduction. If patients can reduce weight 10 percentile of their body weight, along with the medications, there is an increase in the fertility rate. PCOS with lean patients, they can only, without any lifestyle modifications, they can get conceived. But for the obese PCOS, they require all the things. They require regular exercise, they require diet control, they require medications. In thin PCOS, if they want to conceive, only this combination will also improve the fertility rate. Wonderful. But in obese, they require all the mixed basket for their fertility purpose. And menstrual regulation in adolescent, I am generally prefer to give first time if patient is coming, then I am generally prefer to give a hormonal treatment for 2 to 3 months. After that, I can switch over to these combinations for 3 months. And after that, they advise them to regular exercise, diet modifications, and sedimentary life, stress less life, then they can get a result. And every yearly they require follow-up, because PCOS is not a permanent solution, and no any medicines that can cure the PCOS. It is only a lifelong disease that should carry with the woman. Correct. But it can affect all the stages of the woman.
Well, a lot is spoken about the ratio of myoinositol and dechloroinositol.
40:1.
40:1. What is your opinion, madam, about it?
Yeah, I am using in this combination because it is a physiological level of our body.
Yeah. Any adverse effect that you have seen with this type of formulations?
Only this combination, there I had not found a single any adverse effect. Correct. But in PCOS, if we are using clomiphene citrate along with this combination, once in a while we had a mild hyperstimulations of the ovaries. That's why I'm not using clomiphene citrate. Letrozole in a low dose I'm using. but not found. And it is well tolerated because metformin had a lots of problem regarding nauseating feelings, and patients know that this medicine is for the diabetes mellitus.
Yeah.
I am not. That's why they are avoiding these the tablets to take.
Correct.
In these combinations, they are easily take, and acceptance of this molecule is very must.
How soon you see the patient's response?
I had seen along with second or third cycle, I can get a good ovulation. Though they conceive or not conceive, that is
That's
secondary
different.
association.
Yeah.
But good ovulations we can find in second or third month. And
I think
cycle
that
regulations will be within it will also within 2 to 3 months. And the duration of the cycles remain regular for 6 to 9 months after stopping the medications. While in hormonal therapy, sometimes patients cannot regulate. They can have an irregular cycle immediately after stopping the OC pills. But with this combination, I am using for minimum 3 months, along with all the lifestyle modification, whatever I do. Then they had a regular cycle for minimum year or 9 months. They can get a regular cycles. But ovulation start within second or third month of the using these molecules particularly. I am really satisfied with your basket of the medicine.
very good. Thank you, madam. Thank you so much, madam, for wonderful insights. Your patient's
Thank
case
you.
history were just wonderful. We know which type of patients respond. I thank all the doctors who took time from their busy schedule and commitments and attended this webinar. Thanks, marketing team, for conceptualizing and organizing this webinar. As you'll all agree with me, this type of program is successful only because of exceptional coordination from field. Thank you, Hetero field personnel, for a super coordination. Last but not the least, thank you, IT team Hetero, for your support and guidance in all technology-related matters. Once again, thanks all of you. Signing off, wishing you a very pleasant evening. Thank you. Thank you, madam.
Thank you. Thank you. Thank you.